Three presentations, actually, because I can see Peter Helling see the audience or around us. And Philo, will you continue?
Yes, so it's a roundtable on preservation rhinoplasty, and I'm going to welcome the first speaker, Peter Andrews, all the way from London, UK. Peter, the floor is yours.
Okay, so thank you very much. Good afternoon, everybody. I'm Peter Andrews. I'm based at the Royal National Throat, Nose and Ear Hospital in London. I've just put a few pictures up there just to sort of give an overview of what it's like. We were, in that bottom left picture, based in King's Cross in a very old building, but it was all about ENT. That's all you did there was ENT, and it was fantastic. We then moved to a newer building, and like with everything else, there's an element of preservation in moving, but you also lose some bits and pieces too. But we're always expanding. I have a crossover with the middle building, which is Queen Square. That's the neurosurgical building. So that's a bit about me. So preservation rhinoplasty, in my opinion, covers all aspects of understanding the anatomy, number one, getting a really good feel as to how the anatomy interplays, and when you're opening up the nose, more importantly, putting it back into its components, making sure that everything works. So it's all about assessment, and it's all about anatomical understanding and preservation. I'm not a great fan of using words like preservation. I think septorhinoplasty is all about preservation in one aspect, but in many others, it's slightly different. Now, for me, I'm going to give this as my first case. I'll give a brief history, then I'm going to ask Filio and my other panel members to comment. So this is a lady who basically was presenting with left nasal blockage and was referred to me. She's in her early 40s with left nasal blockage, collapse of that external nasal valve, has had previous surgery elsewhere, and in essence, wasn't happy with the way it was working and wasn't happy with the way it was functioning. And as we all know, if you get the function right, then the aesthetics generally follows. And this is the general theme of where we are with this presentation. Any comments from the panel?
Thanks, Andrew. Did she have any aesthetic concerns?
Yes. Yeah. She did. It wasn't significant, but yes.
What strikes me is the width of the middle third. It almost gives you the impression on the frontal view that she has a saddle, and then you look on the lateral view, but the saddle is not there. Yeah. So this is quite striking. And she has, on the basal view, is a wide columella. The tip is, I would call it wide, although the light reflections on the frontal view, they don't give any sign that the domes are wide, but somehow the tip on this basal view appears wide to me. On the lateral view, there is I'd say more than aesthetically pleasing supratip break. There's a 90-degree nasolabial angle. I don't know whether she likes that, and I don't know how she is when she smiles, so dynamically perhaps that drops even further. It's difficult because I only have 3 views. I would imagine that if you test her tip recoil, it wouldn't be fantastic. And if she would have to breathe on deep inspiration, perhaps there is some collapse on the left. Is there a septal deviation too?
A small one. But no, I think...
So there is some, for me, there is some insufficiency on the left lateral nasal wall, not rigid enough to hold, and aesthetically not good enough. Had we had a helicopter view, probably her dorsal aesthetic lines wouldn't be adequate either.
Thanks, Filia. Any other comments from the panel?
Where the osteotomy is complete, because it gives the impression of an open roof.
Yeah. Yeah.
And
Yeah.
also on the left lower lateral, I have the impression that only of inadequacy, but also a prolapse in the internal nose.
Correct. Yeah. And
Yeah.
this is the point of this particular case, because the case gives lots of impressions, but they're not actually the case. Because when it was done previously, actually a lot of the suspensory ligaments, all the things we need to preserve and respect, weren't. And then the nose was put back in the wrong sort of planes.
So
Yeah.
I think that the easy way is to go structural in this case. And I would because I think it's too complicated to go for preservation, especially in the dorsal area. So for me, it would be better to use, for example, some spreaders, not of equally width, to reconstruct the middle third. And I think that maybe on the tip you are on a good way to go with maybe this tip or some slight modifications, but it would be a good idea to go structural on this. I think it's very advanced for performing a preservation rhinoplasty, this one. That's all.
Thank you. So what I'd like to highlight on two areas here, all right? The first area is that middle third, as Philo highlighted. It's quite washed out, it's quite wide, and in essence, it looks like it's disconnected to the tip. The tip's fallen off, and it's fallen off because it's been put back in a way whereby the suspensory ligaments, the various attachments have not been respected. So there's that feeling, particularly on the lateral view, of ptosis. The tip's fallen off, it's not where it should be. The second area, which I'd like you all to focus on, is that left external nasal valve. Now, in the static position, it looks full, doesn't it? And I know, because I know the patient, that they've tried to put batten grafts in there, into that left nasal valve. And in essence, what they've tried to do is just suspend it. They've tried to reinforce it, but in essence, it's just widened that valve area, and it's collapsing, particularly on dynamic approach. So I'm going to put it back to the panel. Okay, I've got permission. Yeah. So those two areas in particular I'd like you to focus on. So back to the panel again. How would you correct that washed out middle third? We talked about spreader grafts, but forget about spreader grafts for a second. How would you reconnect that tip back up to where it should be? Any thoughts?
Try to look into the area of the scroll ligament and see if I can suture anything back there. So I would essentially, this is an operated case, you said, once or twice or more. So maybe there's not much perichondrium of any description, but whatever soft tissue I might find there. I would be also tempted to consider this case, well, it's funny because preservation influences all. I would have been tempted to open that nose given the fact that it's a revision case or a tertiary case. However, lately I have started doing closed even in these cases, and I have somehow found that trying to repair things in a closed approach and not dissecting even further, because let's face it, she's lacking structure, it's obvious, and if I open her up, I will dissect in areas that I will then have to reconstruct. So in essence, I will double the amount of work I have to do. So closed and suture anything back that would look like restoring that scroll connection, if possible. That would be my first thought.
Okay. Smile to the rest of the panel.
Okay, about the scroll area, but open.
I I think that Philio's idea is good, but maybe it depends on the functional issues. You told us she has light functional problems. So maybe you could ignore the real reconstruction and put only something to cover this gap. Something like the SPLF from Roboti or something like this, just to cover the gap.
As a camouflage, you mean,
the camouflage,
George?
only
Yeah.
camouflage technique. It could be a good idea, but it depends, of course, on the quality of the skin. If the dissection of the skin is very difficult, it's better to do for something with closed approach and percutaneous lateral osteotomies.
Okay.
Something like
Okay,
this.
now, so a mixture of responses, which I expect. I think what I want you to highlight, what I want to highlight is that middle photo. What you're seeing in that middle photo is a surprise. You're seeing quite a bit of fullness in the dorsum, aren't you? You can even argue a pseudo-hump. And with preservation rhinoplasty, the whole concepts are not necessarily removing what you see, but rearranging and preserving and putting things back again in their right order. So just keep an eye on that pseudo-hump. It was never operated on, as I'll show you the photos. It's just, it disappears with reorientation. So that's point number one. The left external nasal valve was a problem, a big problem, and that was the main reason why the patient was referred to me. So it really needed to be addressed, hence I had to open the nose, just to sort of create more stability, etc. So I'll move on and just go over some basics of what I'm trying to get across today with this case. So it's all about, in my opinion, repositioning the nasal tip, the lower laterals, back onto the anterior septal angle, back onto that caudal septum. That's key. Now, if you look at these two photographs, bottom left, sorry, my pointer doesn't work. Actually, the two, they're incorrect, interestingly, the way they've been positioned. If you look at those two grey photos, you can see the one to the right, you can see how the lower lateral has fallen off the anterior septal angle. Can you just see where the anterior septal angle is, just poking out? Those upper laterals need to be back onto that, yeah? And if they're not back onto that, you get this washed out effect into the middle third, and that's what you're seeing with this lady, that washed out lostness. And also you then create a pseudo hump because the whole tip's fallen down. So that's key number one. Number two is, in order to lift that tip back up again, you do need to augment it. That can be done internally or externally. It's just with external approach rhinoplasty, that's my preferred method. Now, she's had ear cartilage taken from both ears. So for me, it's about obviously harvesting cartilage from elsewhere, which is rib cartilage. I tended to use autologous graft cartilage at the time, although you can use Tutaplast, etc. So that's point number one, is readdressing that washed out middle third, bringing the tip back up, but also resuspending the tip. So the tip infrastructure, those two lower lateral cartilages have actually toast down. So you do need to resuspend it with some form of hard cartilage like rib, and then rotate it up, reconnect it to the anterior septal angle. Now the approach I did was an open approach. I'm not going to go into great detail as to how I opened it, but correct, it was a revision case and it had its challenges. But in essence, this is a case of, okay, you can use rib just as a caudal strut, but equally you can use it as an external nasal valve opener. And that's what I did. We called it a J strut. It's been described in other ways. You can use it as a pyramid strut. But in essence, what that particular rib graft is doing is repositioning the lower laterals in a more projected, rotated way, and then the lateral crus of that left lower lateral then is placed over that J. So it keeps it open. Now, I've taken all the other augmenting cartilages out before I did this, and this is one way of doing what's called quite significant tip external nasal valve reconstruction. It is effective and gives you good long-term results. So that's my approach. Did I take off the hump? No. Did I do any bony work? No. Did I put spreader grafts in? No. The septum was relatively straight, but the problem was the caudal aspect of the septum wasn't great. Number one, the lower laterals had fallen off. Number two, so I had to reposition and in my own mental mind work out how that lower lateral complex best sits on the anterior septal angle. So this is a sort of overview of what we did. Now, this has been described in many other ways. Dean Toriyami talks about the lateral crura rib extensions, right, or battens, which then go onto the nasal wall. They work beautifully too. But this is a technique which I used as an individual case. And it's just something to maybe bear in mind. The other thing worth noting is the fact that don't jump in when you're doing preservation rhinoplasty or any preservation work thinking that that photo top right needs a similar operation. I made the mistake thinking it did. The reason why it didn't was because of, at the time, I didn't truly understand the interrelationship of the tip. The reason why she's valving on the right is the Bernoulli effect, number one. It's the better airway. The left side is blocked. But the real reason it's valving on the right is because the medial crura of the right lower lateral cartilage isn't attached to the caudal septum. So the caudal septum's sticking out the left nostril, where the anterior nasal spine is, and the right medial crus is just lying fallow, right? It's really weakened. And this is the message today. You know, understand the ligament attachments, understand where that medial crus needs to attach. So the three major tip supporting mechanisms is obviously the lower lateral cartilage itself, the intrinsic strength, which was weakened in this lady, the scroll area, as Filio alluded to, and that's the reattachment of the lateral crus over the upper laterals. That scroll area is really, really key. And the third is the medial crura, and that was the only weakness in this lady. What I did was a mistake. I opened her up and put ear cartilage in. She didn't need that. What she really needed was an anterior septoplasty through an open approach, repositioning of the anterior spine, and more than likely, her external valve would have been fine. Now, the story in the end was fine, but it's just a learning curve of preservation, understanding the anatomy before you just jump in. So these were the long-term results of this case. And that photo on the left basically shows how that tip has slightly rotated up. It was 100, it's now, you know, well, it was 19, it's now about 100. The pseudo-hump has sort of disappeared in the repositioning of the tip, so it's more smooth. I didn't take anything off the bony aspect, that was preserved. The front-on angle is an improvement. If I was going to be critical, obviously the tip-defining points aren't exactly symmetrical, and on the basal view, there's a small irregularity around the nostril, but she wasn't concerned about that. Like everything else, it's always the 18-month post-op you need to see, and that's the photos I've just shown you. Particularly in revision cases, just be wary of the fact that at 4 months it's still swollen, and it's all about reassurance. So that's the journey of where we are. The bottom right photo shows quite a wide external nasal valve, and when you're working in the NHS and you're going to do functional surgery and you want to discharge these patients quickly, you make it nice and wide so it works. And then she was happy and we discharged her, all right? So that's my case. I will then hand over. Any questions on that?
Thank you very much, Andrew. Are we taking questions from the audience now?
Yes, of course.
Any questions, anybody? Don't be shy.
Or comments?
We're keeping it interactive, so it's like a discussion. Or comments or queries. Yeah, please.
Hello.
Would you use diced cartilage as a permanent camouflage repair for this type of rhinoplasty?
Probably not in this case, but I think diced cartilage has a really good augmentation effect. You can mold it, it works well, particularly in that middle third washed out area. But in essence for her, it was just the fact that actually it was disconnected. And once reconnected, that defect filled itself in, I think. But no, I think diced cartilage has its uses, and potentially you could have done that at the beginning. It was commented on initially, you know, a camouflage augmentation approach. But no, I wouldn't have used it necessarily in this case. No problems.
Anybody else would have done anything different?
Especially for the left lateral, lower lateral.
I would ask, why didn't you try to use the spreader graph, and maybe it would have, I think, a symmetrical result, and also fixing the valve issue?
Yeah, and it's a good question. So for this lady, actually, the internal nasal valve was okay. Hadn't been touched. It was okay, and it was all about inspecting it at the time, thinking, you know, that's well proportioned. It had good internal strength. I'll leave it alone. Enough's been done on this nose already. But I like your idea. What I could have done, right, and it's a fair point, I could have put bilateral spreaders in, potentially extension spreaders, yeah, and then reposition her own lower lateral over that, yeah, to create that lateral strength. And that's something I could have done. But I think on the table, and you got to take my word for it, there was very little left of the left lower lateral. You can see it in some of the, it was very weak. So that in itself had to be addressed. So that was sort of my priority at the time.
Andrew, was it more of a functional case, this?
It was NHA, yeah. I mean, everything through the National Health Service is fundamentally functional.
That anyway influences a little bit your algorithm and your decision making, isn't it?
Absolutely.
I mean, we're all in the same position. Okay, yes, please.
It could be a solution, lateral crural strut for this valve problem, or not?
I like it. I like that technique. I did this case several years ago. I think the lateral crural strut, mobilizing the whole of the lateral crus, you know, and then reattaching 2 extension rib grafts as lateral crural strut is fantastic. Very much the Dean Torriami technique. He gets wonderful results. And I like the way it really does prevent the valving. But he still uses rib. It's just different ways of doing it. But I do like that technique.
Yeah, anybody else? There was a hand raised there. Yeah. Yeah, please go ahead.
Just mentioned lateral crural.
Ayler strut graphs, yeah.
Maybe articulated lateral crural, that would be an option. But talking about spreader graph, as it says in the literature too, the spreader graph doesn't help for the intranasal valve. Actually, from the beginning, it was introduced as an augmentation of the nasal dorsum, and somehow the discussion turned to that it will improve the internal nasal valve. But if you look at the literature, it is stated that it doesn't help for the internal nasal valve, not all the time.
It depends which literature you're reading. I think the jury is out there for that, but it's a big controversy, and there are studies that support the idea and studies that are against it. So, well, some evidence against it. So, yeah, it's a hot topic.
I think the take-home message is that relationship between the internal nasal valve and the external nasal valve. So if your internal nasal valve is strong, well supported, with good internal architecture, then you can reposition that scroll area. Because the scroll area is all about that lateral crus relying on the internal valve, if that makes sense. Now, it's all well and good relying on the internal nasal valve if it's working. If it isn't, then you're stuck. And that's the take-home message. I think what you're trying to allude to is the fact that there is an interrelationship between the two, and whether spreader grafts work in people's hands or not is obviously down to our own personal experience.
Yes, go ahead.
I kept the patient's complaints quite open to the panel. Because it was purely functional, really, I wouldn't. Okay? A closed technique is a good technique if they've had 2 previous external approaches. Now, this lady has had a previous external. A closed technique could be an option where you could go in and aesthetically improve it, maybe with some camouflage grafting, etc. The problem with the closed technique is that you're not necessarily going to get that lift, that repositioning of the lower laterals up over the upper laterals and closing that dead space. That's what you're going to miss. So it'll always remain quite a long nose, potentially. But yeah, external definitely for functional.
Anybody else?
Then I think it's time
George,
for
anything to add? from your point of view? Okay.
The
Okay.
judge come for
The
you.
only thing I could add is that the idea of using spreader graphs was not in this case to open the internal nasal valve.
Yeah.
It was to give a better shape of the middle third. Okay? Just to be clear. That's why I said that maybe someone could, including me, use spreader graphs. And of course, I think I totally agree with Philio that it's a big controversy if the spreader graphs help or not. Most of the published works are considered that it helps to use the spreader graphs. Okay? Just to make it clear.
Okay.
All right. So thank you very much, Andrew. It was
Okay.